Okay, now we get into gastroesophageal reflux. This is a transient relaxation of the lower esophageal sphincter, so that sphincter between the bottom of the esophagus and the top of the stomach. Kids with GERD, you'll see a failure to thrive. You may get bleeding from the irritated esophagus, and then dysphagia. Usually they have a delay of gastric emptying time, so food just stays in the stomach longer, and that gives it more chance to reflux up, and when they reflux, that puts them at risk for aspiration and aspiration pneumonia. One of the ways they'll evaluate this is to put down a pH probe, and this can be kind of a NG, or actually they also have them in a capsule that they can swallow that has a little string, and you tape the string to the cheek, and it has a probe on a couple different points, so it measures the pH in the stomach and then up in the esophagus, and they usually have a little box that goes along with it that you hit a button that gives a date and time marker on the printout that it makes every time they eat. And then they'll watch that pH up in the esophagus, which it shouldn't be acidic unless those stomach acids reflux up. And they watch and see how much refluxing there is and for how long after the meal. So the treatment for kids who have reflux, on infants we can try small thickened feedings, so smaller amounts more frequently, and thick so that they're a little heavier and don't reflux as easily, and then positioning. We don't want to lay them flat after they eat. We want to have them up while they're eating and for an hour or so afterwards. We can use medications. These are similar to the ones we use with adults. Your H2 agonists, Tagamet, Zantac, and Pepcid. You'll see Reglan used a lot in children. Your book says it's a little bit controversial, but it increases the pressure of that lower esophageal sphincter, so it makes it tighter, so it's harder to reflux, and then it also speeds up the stomach emptying. So the stomach empties faster, you just have less time where there's a lot of stuff in there to reflux up. And kids who are really having problems with it, they'll do this Nissen fundoplication, which is a surgical procedure. And here's a picture of a Nissen. They take the top of the stomach and wrap it around the lower esophagus, so it kind of makes an extra sphincter around the base of the esophagus there. The top of the stomach around the base of the esophagus. GERD medications. We have our H2 receptor antagonist. That's why I slowed down when I said it before. It said agonist, and I was pretty sure it's supposed to be antagonist, and it is, which reduce your gastric acid. That's Tagamet, Zantac, Pepcid. We have our proton pump inhibitors, and these reduce the gastric acid secretion, so you make less. And they also increase the tone of that sphincter at the top of the stomach, the base of the esophagus, and it promotes healing in the esophagus. So these are Nexium, Prevacid, and Prilosec. And as I said, Reglan is used very widely in our area, not just with kids, but the adult hospitals too. However, your book says it's a little bit controversial, so it's not used nationally the way it is locally. There's some other GI problems kids can have. Functional abdominal pain. This is described as nearly continuous abdominal pain in school-age children or adolescents, and it really is not related to eating or menses in girls or defecation. It just happens. We don't really know what it's related to for these kids. You can also get irritable bowel syndrome, and that's abdominal pain that's associated with bowel movements, or abdominal migraines. And this is paroxysmal episodes, so they are sudden and intense, and then they go away, of severe abdominal pain. And between these episodes, kids are completely normal. All of these, they often can't find a true cause, and we just kind of treat the symptoms. And you'll get some people who act like, because we can't find a real cause, these must just be in the kids' mind. They're making them up to be manipulative. These are real syndromes. But they're syndromes, which means we don't really understand them very well. Okay, appendicitis. If you've been upstairs on Explorer, you've probably seen some kids who came in with appendicitis. This is the most common abdominal surgery of childhood. In kids, we see a lot more ruptured appendixes than we do in adults. And part of that is kids just have vague symptoms until they actually have the appendix rupture. So it's very hard to know, do they have the flu, do they have, what's going on. They complain of stomach aches for so many things that it's hard to be sure it's an appendicitis until it ruptures. So the pathophysiology that's going on, you get an obstruction in the appendix, and usually this is a bit of fecal matter. The appendix is a little finger-like protrusion off the side of the intestines near the ileocecal valve, and a piece of fecal matter gets stuck in there that compresses the tissue and the blood vessels of the appendix, which makes it a little bit ischemic, which gives it the perfect opportunity for bacteria to get into the tissue. As it swells and gets more ischemic, it will eventually, or can eventually, rupture or perforate. That fecal matter and infected material inside of it spills out into the peritoneal cavity, causing peritonitis. And that is the life-threatening complication of this, is peritonitis. Kids often will develop ileus, so the peristalsis in the GI system just shuts down. Here's a picture. You can see that appendix sticking off there, and that's what it should be, just a little protrusion or finger-like thing that sticks off. And here's one that's very large, red, inflamed, not ruptured, but definitely an appendicitis. Now, diagnosing it is pain. It's at McBurney's point, which is your right lower quadrant. You'll see elevated WBCs, particularly in the stabs and the bands. If you look at the differential, so the different types of white blood cells, they'll have a fever. They'll do an ultrasound. Usually they can do a CT scan to try and see what's going on in there. They say a lot of times you really can't be sure on appendicitis. So they go in and take it out and find out, oh gosh, it was just a bad flu. But you can't be sure until it ruptures. And they prefer to not let it rupture, but it's not an absolute when you're trying to diagnose this. So thank goodness that's the doctor's job, not ours. When it ruptures, the kid will usually have a sudden relief of pain. All that swelling, that pressure that was in the appendix is gone now. They feel better, but only for a short time. Then they develop peritonitis, where they are really acutely ill. The management, usually they'll go in laparoscopically and take out the appendix. They'll put them on antibiotics, give them IV fluids, and pain management. Now, at Children's Hospital, and your book doesn't go into a lot of detail because I think this isn't really clear-cut across the nation how this is managed. At Children's, what they're finding is it's better to delay surgery. We put them on aggressive antibiotics and IV fluids, let everything heal, and then later on, after the IVs are all done, we can go in and take out the appendix. We can hopefully no abscesses have occurred, but if they can, we can clean those out then. What we found is we get less scar tissue. When you go in and do surgery while everything's red and hot and inflamed, a lot of scar tissue develops, and that can cause problems later on. These strings of scar tissue that develop just kind of from one spot to another, they just attach onto things and you get these strings. And if we wait, get all the infection under control first, we don't get that same level of scar tissue developing. The appendix, your food, it sticks off to the side. Your food doesn't normally go through it. So we can, after a couple days, we can usually let these kids eat again and just keep them on the IV antibiotics. So anyway, that's the current treatment at Children's, which your book doesn't really talk about. There's a couple different ways to do laparoscopic surgery. They put in a scope and they put in a lot of gas, blow up the abdomen so they can see around well, and then they'll put in a little instrument where they do the incision and do sutures and do everything. The nice thing with laparoscopic is the healing is so much quicker. It's just so much less invasive that people heal quicker. Usually at Children's you'll see the 3 sites, or sometimes they'll do 4 sites, but they usually use the umbilicus as one of them. So it's more like the picture on our right. Okay, Meckel diverticulum. This is a little bit of a remnant from the initial yolk sac when the fetus was initially developing. Has symptoms similar to appendicitis, but it'll also include painless rectal bleeding, and the treatment is similar to appendicitis. They need to go in and take this out, and then treat any post-op complications. On the exam, I'm not going to ask about ulcerative colitis or Crohn's disease. I believe you cover those in your adult med surg, as well as peptic ulcer, hepatitis, and cirrhosis. Biliary atresia. This is progressive inflammatory process that causes the bile duct to fibrose, or it can be a congenital absence of the biliary duct, or it's non-patent, so it's there but nothing can move through it. These kids, the symptom we see is they come in with jaundice at 2 to 3 weeks of age. They have pale stools and dark urine. That's where the body's trying to get rid of the bilirubin in the urine. That makes a dark urine, where normally you excrete it in the stool. If this is untreated, it will lead to liver cirrhosis, liver failure, and death by 2 years of age. If we can do surgery before the child's 10 weeks, so if we get it diagnosed quickly, they have a much better prognosis, and the treatment is a Kasai procedure, where they take a segment of the intestine and create a bile duct. They anastomose it, so they hook it on both ends and make a little bile duct, so you don't get that buildup backing up into the liver, causing liver damage, and then you also get normal digestion. Now, 80 to 90% of these kids will eventually need a liver transplant, so it's not a perfect or lifelong fix for most of these kids. And here you can see the Kasai procedure, where they've taken the intestine, connected it up there into the liver, and then from the stomach, that part of the intestine kind of hooks together. So they basically make a Y out of the intestine, where it was just a straight line before, because that bile duct doesn't lead from the liver down to the duodenum, the top of the, or just below the stomach in that first section of small intestine like it should.